All right, so the first presentation is a short presentation on pediatric vital signs. Oh, okay, got it. So, I think they're not just numbers. They help us in the clinical assessment of a patient. They help us to establish a baseline for the clinical encounter and help guide treatment and effectiveness of treatment. So, they are vital, which is, I guess, why everyone wanted to hear about them. So, there are some pediatric precautions. Okay. All right, there we go. In terms of vital signs, which, as I wrote this, I thought about it, and I think especially in the emergency room, this could apply to adults too. Anybody in pain, anybody out of their element. So, but particularly for children, fear of the surroundings, equipment, pain, stress, fear, all of that compounds to increased heart rate, respiratory rate, blood pressure. And so sometimes the interpretation of pediatric vital signs can be a little bit confusing, not just because the norms vary with age, size, gender, but they also vary with technique, and they vary with the basic clinical state of the patient. On top of that, the norms that are established vary between groups. So usually when I feel like I need to look at a norm for an age group, I'll grab a PALS card, which has all of the norms on there. So those are the norms that people tend to gravitate towards. I mean, they're not wildly different across different organizations, but there's definitely some variation that you'll encounter. So in this brief presentation, we'll look at interpretation of heart rate, respiratory rate, blood pressure, temperature, oxygen saturation, and just some overall trends in terms of pediatrics and sort of pitfalls in measurement. This is one such organization by age, and I did, if this works, okay. I did think this was handy in terms of quickly looking at a systolic blood pressure by age. So you would take age times 2 and add it to 70. And I believe you can also find that on the PALS algorithm. The weight one is also kind of handy if you're, again, kind of thinking of the ED, but you're stuck there and you don't really have a weight on this patient, and parents can't think of it, and you're, and you don't feel like whipping out the Breslow tape. You can get an estimate of that might help you in terms of what age the patient is too. So you can get a heart rate by feeling a peripheral pulse or by direct auscultation. It's best to do it for a longer period of time. I find that as well, especially in kids, because they're based on what they're doing, how they're feeling. You can obviously get the heart rate from a monitor, but if you're taking it yourself, you can get a little more information on the quality character. So heart rates are fastest in infants, and they decrease with age. And normal heart rate for an awake, healthy term newborn is between 85 and 205. So there is a fair bit of variability there, and it is important to note that sinus bradycardia during sleep is really common in infants and children. So usually, as long as they're well perfused and they're otherwise healthy, it's not really a reason for concern. But it's not an uncommon thing to be called about in the nursery for heart rates somewhere in the 70s, and generally the infants are otherwise well. It's not an issue. As children get older, their heart rates slowly decrease until they're around age 10, when they begin to approximate normal adult values. So you'd get a normal somewhere between 60 and 100. Not unlike adults, sort of based on their height and weight and baseline level of activity. Respiratory rate can be a little tricky because it's one of those ones that you can consciously control. So ideally, you know, you might try to get this while you're doing something else in the room, or, you know, just kind of talking to parents, so the patient doesn't know what you're doing. Again, respiratory rates are fastest in newborns and then decrease with age. So in infants less than a year, you can have ranges from 30 to 60, you know, more likely on that upper end. And then obviously in the nursery, we often have babies with some transient tachypnea who might be above that range and still look comfortable and pink and otherwise be doing well. Once they leave the newborn nursery, they shouldn't really have respiratory rates over that 60. And again, respiratory rate gradually decreases and approximates adult ranges by the time kids are, you know, early teens. Oh, I don't think I meant beats per minute, but
Breaths per minute.
Yes, but I always think of BPM as beats per minute. Blood pressures. So yes, I think this is probably the most difficult one, and I wish I had some magical words of wisdom on taking blood pressures in little ones, but this is probably the scariest vital sign for kids, you know, because you're putting something on them. It squeezes, it feels weird. Generally dislike everything about it. And it's unfortunate because preparation is kind of key to taking an accurate blood pressure, but when you're dealing with all of the points in number one, that can be a bit of a challenge. Ideally, you would have a patient seated, the back supported, the arm level at the heart. And this sort of applies more to older patients, but resting and, you know, those teenagers who have their caffeine and their sports drinks, energy drinks, whatever. You kind of want to make sure they haven't had those recently. The cuff should encircle at least 80% of the arm circumference, and the bladder width should be at least 40% of the arm circumference. Now, you know, pediatrics has such a broad range, so you might need to go searching for the right cuff size. And certainly in some of our adolescents, they're bigger than I am, so you know, you might need to be searching even for a leg cuff on for some of those big kids. A cuff that's too small overestimates the blood pressure, and a cuff that's too large can slightly underestimate the blood pressure. This has a reverse trend to the other vital signs we've talked about, so unlike the others, blood pressures start low and then increase with age. So it's kind of general categories. Term neonates, the systolic blood pressure should be above 60. Children 1 to 10 years of age, the minimum systolic blood pressure should be around 70, and 70 plus the age in years times 2. So that little formula we saw. And for children greater than 10, the systolic blood pressure should be over 90. It's probably not critical in an emergent situation to be getting exact norms, you know, as long as you're perfusing and your systolic blood pressure falls within a normal range, then that's fine. You know, usually we'll go to those more complex charts of blood pressure by age and gender and height. If it's a child that we're following for a renal disorder or otherwise is being followed for high blood pressure, then we'll go to the tables. In kids, hypotension is a really late sign of shock. Children tend to compensate until the very last minute, so it's not as reliable an indicator. Kids will look good until they don't. So temperature varies a lot depending on where it's measured. It's not so much an age sort of thing. It's more the site. Ideally, you want to measure a patient's core temperature, but you know, you can take surrogates from other sites. In our babies, we prefer rectal temperatures, and we'll tell parents as well while they're infants that we prefer a rectal temperature taken. Obviously, there comes a point when you're no longer doing that on your patients. Oral temperatures are good for those older than 4 who can cooperate and place it under their tongue. Tympanic temperatures can be somewhat variable depending on how much earwax there's in there and how deep it's put in and all of that. Axillary temperatures are the farthest from the core and can be pretty imprecise depending on what condition the patient is in. So the rectal, oral, and tympanic temperatures give the closest estimates to core temperature. Oral ones tend to be a little bit lower. And the axillary temperatures are consistently colder. So there's a lot of variability, but not with age, so it's not necessarily a pediatric thing, I guess. Where it matters more is in our very young infants, where we might do a sepsis workup if the temperature is over 100.4. And then again in neonates and especially our preterm babies, they're prone to hypothermia. And in those babies, we look at hypothermia not just in terms of environmental factors, but as a possible early indicator of sepsis. So I do feel like sometimes those babies can come through the ED with, VNA has seen a core temp of like 95, and then they're brought in, and we do worry about that as well. So pulse oximetry is a measurement of arterial oxygen saturation placed on the child's finger or ear. I mean, we mostly use it on the finger, toe, wherever you can get it to stay. Lots of sources of error, either poor perfusion because the child is hypothermic, there's lots of motion artifact, older kids, they might have nail polish. And something to note too is that it doesn't really speak to poor oxygen delivery, so if the child is anemic or there's decreased cardiac output or some other anomaly that's interfering with oxygen delivery, it doesn't tell you about that. So trends with age, outside of the nursery, there's not a lot of trend, but certainly in the immediate newborn period, we tolerate oxygen saturations that are a lot lower than we would once they leave the newborn period. And beyond that, then they're pretty stable with age. I think what I would like to point out that especially with our little broncholytics on the floor, there always comes the time where people tolerate different oxygen saturations as a baseline, and there's a lot of debate in the literature as to what a normal oxygen saturation truly is at baseline. Most of our data is gathered from kids in the hospital. We don't have a huge pool of O2 sats from kids out in the community, just normally hanging about. So there's probably a percentage of kids that, lives around 90 or thereabouts, lower potentially during sleep. So, some of my colleagues might want O2 sats greater than 93. I tend to say 91. Some of my other colleagues, go along with that. So every winter there's a little bit of talk about what constitutes good O2 sats. So not firmly established. Somewhere around 92, 91, somewhere. You have to pick a number. In an otherwise normal, healthy kid who's not sick, then that might prompt concern. So overall, vital signs do vary with age, some more than others. It's important to use age-adjusted reference values. Measuring respiratory rate from the bedside when the patient is not aware of what you're doing is a good idea. Using an appropriately sized blood pressure cuff is important. And rectal, oral, or tympanic temperature gives a more accurate reading of the core temperature. let's just say then axillary temperature. And pulse oximetry can be a useful tool, but it does have its limitations and sources of error.